So with this issue of how you choose, your first therapy, we get asked fairly frequently by pharmacy benefit providers to give us an algorithm, because that lets them know who to go negotiate with first. Start with A, then B. And there's some disease states where you can do that. I don't think you can do that in MS. I think that you well know the conversation on choosing a therapy is about an hour long. And the American Academy of Neurology, in their guidelines, one of the wisest things they put in there was that you should do the diagnosis on one visit and the discussion of the therapy on the next visit, because A, they're both very complicated, and after you do the one, the patient may not be in a position to really choose. But there's so many different factors. There's your assessment of how active their disease is and what their prognosis is. As difficult as that is because of our lack of ability, their risk-taking capacity, what they've learned from the outside, where they are. Pregnancy, we do the second most family planning at our institution after the OBGYNs. In fact, my wife's just saying, you ought to get pictures. We make them bring the babies in. But it's a big part of what we do, because very often someone will come in, a young woman, that's our modal patient, and there'll be a decision, well, we're going to put you on this medication, and you can try and start your family. And then there's, insurance issues and what route of administration they want to take. And so there's quite a bit involved, and it's a long conversation. And at least my view is we don't have this kind of algorithm. Thoughts?
I'd agree.
I would agree. Everyone's different.
Right,
yeah.
right.
So one of the questions here we're asked to discuss is what therapies to use as first-line treatment. And I think I'll turn that around and say, what therapies wouldn't you use as first-line treatment? Amit?
Other than alemtuzumab, probably, or bone marrow transplantation as an unapproved therapy, I think all the therapies in the armamentarium could be considered for first-line therapy.
Yeah, I would agree with that. I mean, recognizing that higher efficacy medicines probably work best in early, highly inflammatory disease, I still think very few patients up front merit the risks of those strategies. And so I would use, or at the very least discuss, all of the others.
I agree.
So we're all in agreement. And I think that what we're seeing out there was, in fact, as we get more and more agents along, and certainly more of the higher efficacy, what we think are higher efficacy agents, we're seeing their uptake faster and sooner. And sometimes even not following the label per se, waiting, there's all these different labels that aren't necessarily based on the data, but rather on some opinions. But I think that's probably right.